Okay, well, management of severe traumatic brain injury in low resource settings is the topic I've been given. I'll start with a couple of points. One is, this is the average ICU in high income, high resource centers. It has lots of fancy toys. This is probably the rest of the world where there are no fancy toys but good people. So which do you want? Notice that in the fancy toys picture, there are no people. That's probably what you don't want. So with no fancy toys, good people, that's what we studied basically in the BEST TRIP trial, the randomized trial of intracranial pressure monitoring, where we studied two protocols. We studied a ICP monitored protocol, and we studied a protocol using imaging and clinical examination, but no ICP. And we found equivalence in the outcome in that study. We found more efficiency in the ICP monitored group, but the overall outcome was the same, which really very strongly indicates that you can achieve good outcomes in the majority of severe traumatic brain injury patients without ICP monitoring. Point two, if you have limited resource money, where are you going to put your money? ICP monitor or a CT scanner? Okay, no question there. How about ICU bed versus CT scanner? How about ventilator for those ICU beds? How about simple fluids? Many places, the patient has to be able to afford the fluids to get them. Yet if you don't resuscitate a brain trauma patient, they're just not going to do as well. Pre-hospital care, well, we know where the money should go there. How about post-hospital care? All that work you do in ICU and surgery, without post-hospital care, not so good. So we have pretty good direction of where our money should go. I'm not saying take away your ICP monitor. Clearly, that's not what I'm saying. But for much of the world, the answer is, should we monitor ICP, is no. Not really no, it's really not now. But that doesn't mean we can ignore severe head injury, and that's really the message here. And if you really want to monitor ICP, you can become imaginative. In Cuba, for years, we used a nasotracheal suction catheter for children, pediatric, and that was the ICP monitor, and it cost cents. So if you need to monitor ICP, you always have the tools. But what's the number one drug in TBI? Despite all the billions spent on research, it's resuscitation fluid of some sort, but it's resuscitation fluid. The most important tool, sorry, it's CT scan. You gotta be able to see what you're treating. The most important monitor, it's the clinician, not the toys. So we all have those. We all can manage that. So you can achieve good outcomes without ICP monitoring, but not without good medical care. So what constitutes good medical care? Well, we've been working on that in Latin America for well over a decade now, prospective data collection and some randomization and some simple group studies. And over the last 5 years, we've studied a protocol in terms of managing patients without ICP monitoring. And I'd like to go over that. It's currently in press in NEUROTRAUMA. So this is page 1 of the protocol. And the first question is, who should you treat for suspected intracranial hypertension? You don't have a monitor, so you have to suspect it. Well, the criteria are one major criteria, which are CT scans showing Marshall 3 or Marshall 4, compression of cisterns or midline shift more than half a centimeter. Or you can have two minor criteria, Glasgow Coma Scale motor score less than 4, pupillary changes, or a Marshall diffuse injury 2. 2 or more of those, you're classified as having suspected intracranial hypertension, and you should go to treatment. Now, in order to do that, you need a certain number of CT scans. And as you know, CT scans can be expensive, and you sometimes have to leverage them with social work, et cetera, if the patient can't fund it. But they're so important that we came up with a schedule for CT scans. And I'll tell you a little bit more about that in a bit. So that's the CT schedule. So now what do you do once you start that? Well, you start the basics of care, keep the mean arterial pressure threshold up, and then you initiate tier 1 therapy. And they chose hypertonic saline over mannitol, but that isn't critical. But it's the tier 1 is hyperosmotics given on a scheduled basis. That's every 4 hours in this case, but every 4 to 6 hours. Because you don't have instantaneous ICP, but you have suspected intracranial hypertension, so you're treating it in almost a prophylactic sense. So once you've initiated tier 1, what happens? Well, you keep examining the patient. If they don't make progress and you want to advance your therapy, you first ask yourself, have they deteriorated acutely? If they've deteriorated acutely, which is quite clearly defined as a Cushing syndrome or drop your motor score or change your pupils, that needs immediate investigation and treatment. That's called neuro worsening. But if in general they're just not making progress and you want to escalate your treatment, then how do you do that? And what we have are tiers of therapy. Tier 1 you saw, that's the first tier to be used. If that isn't effective and you want to advance, then you can advance to tier 2 using one or more of those therapies. And then tier 3 is the most extreme therapies when you're really having trouble, or maybe in the instance of neuro worsening. There were a number of treatments that were decided not to be included, actively decided not to be included. And there was one, neuromuscular blockade, that some centers were for, but some centers were against because you lose your exam and that's so important. So it was unresolved. So neuromuscular blockade was unresolved. So these are the tiers of advancing therapy. Now, at some point, you're going to decide that the patient is potentially ready to be weaned. That's difficult to do when you don't have an ICP monitor. So how do you do that? Well, what we did was, of course, first you examine the patient to assess the neuro exam. And if the neuro exam is compatible with potential weaning, you ask, what are the pupils doing? What's the motor score? And what's current CT? And then there is a heat map to help guide you to help with that decision. Now, there's very controversial. People have their own opinions on this. We could not get solid numbers. So what we did was created a heat map based on how long it's been that the patient has appeared favorable, what the GCS shows, what the CT shows rather, what the Glasgow Coma Scale motor score is, and if the pupils are normal and abnormal. So all of those fit into one of these boxes. And then we asked everybody, what would you do in this individual instance? And we used a traffic light to put all of their votes into each box and determine what they would do. So green is, yeah, I would back off. I would start weaning treatment. Yellow is, I would think about it and maybe consider some more things or wait a day. And red is, I definitely would not do that. And this heat map has been tested now in several hundred patients, and it's actually been found quite useful to help weaning therapy when you don't have an ICP monitor. It's really not an easy question. Does having a protocol improve treatment? Well, that's a good question. In our studies, and we've now done 2 different ways of looking at this, it clearly was associated with a better outcome. So not having a protocol versus having a protocol, the protocol people had better outcomes no matter how we measured it. That's the Kaplan-Meier survival curve, was quite definitely statistically improved with a protocol. Interestingly also, it was more effective in terms of number of treatments and ICU days. So it also cuts down the duration of treatment and the number of ICU days. So it's effective, which we like, and it's efficient, which your administration likes. That's a pretty good combination. When reading literature from high resource countries, what should you do in non-high resource countries? Should you adopt those ideas or should you adapt those ideas? Well, most of the ideas from first world countries don't apply. I mean, for instance, we have unbelievable pre-hospital care, helicopters, fixed wing, ambulances with very well-trained people, okay? In Colombia, they have a lot of taxi drivers. They don't have many ambulances, and the ambulances they have don't have any, they just put you in the back and drive you. But the taxi drivers were a resource. So what can you do with taxi drivers and medically injured people? Well, it turns out they pick them up and they bring them in. So what you can do is teach them what to do. You can teach them in basic life support. Provide them with an advanced first aid kit so they don't throw the patient in the boot of the car. You give them a sheet of plastic. You give them some gloves. You give them something to stop bleeding, etc. You allow them to obtain a new kit. So when they bring a patient in, they get a new kit. You reimburse them for patient delivery. You pay the taxi fare. And you can have companies or insurance agents fund the kit. So it's a cost neutral system. Everybody has a cell phone. So now you have a pre-hospital communications. I'm bringing in a patient with an injury. So this is a superbly cheap way of building a pre-hospital care system. And it was done in Ghana, in Africa, by Charlie Mock, where he educated taxi drivers in pre-hospital care. And as a result, 61% of them reported after the course that they had done so, that they had provided pre-hospital, potentially life-saving care during transport. That is cheap and effective, and it gets around a big problem. The New England, we had a very erudite presentation of the decompressive craniectomy bits. The DECRA trial, when decompression was done very early, showed probably no benefit, done too early, really, possible harm. The rescue ICP trial, decompression done when ICP is becoming refractory, done later, showed decreased mortality but quality of life issues. But Is your reality the same as in the UK or Australia and New Zealand? Probably not. So what is the utility of decompression craniectomy in LMICs? Well, you can leave the bone off at surgery, primary decompression, or you can take it out for swelling, which is usually based on an ICP monitor, which you may not have. How about a third indication in LMICs? There is a huge number of patients, which we called in Spanish pacientes huérfanos, which in English is orphan patients. They're not orphans, okay? But what they are, they're patients who come into hospital who need an ICU bed, but there aren't any beds because they're all full. So they end up going to other areas and they receive, and they may be intubated, but the ventilator is someone who can fall asleep. It's not a mechanical ventilator. And they have decreased monitoring, decreased nursing care, decreased interventions, okay? And there's a lot of them. This is a fairly famous trauma hospital in Brazil where 72% of severe traumatic brain injury patients couldn't get an ICU bed. So they're common. These were never, they do not exist in the US and Europe. They've never been described in the literature, yet they're huge. They exist because of the number of patients, the shortage of beds. I have 512 total beds in my hospital, but I have 128 ICU beds. Okay, most LMIC centers have less than 5% beds. So you never have enough beds. How many people here have had traumatic brain injury patients come in who need to go to ICU, but there's no available ICU bed? Everybody. Yeah, exactly. If you ask that question in the US, they don't even understand what the question is. It's a huge question. And if you do so, if you come in late and you don't get into ICU for 24 to 48 hours, you do worse. Especially if you have a swollen brain. So it's unfavorable to be an orphan patient. So here's a question. You can do one of the two well-known ones, or you can consider a third indication. How about decompressive craniectomy in select patients when the needed ICU resources are limited? Now, this is just a suggestion, but how about a young orphan patient comes in with a swollen brain, pupils work, no ICU bed? Would this patient be better served by decompression and treated on the ward? Or just put on the ward and let die of what we suspect is intracranial hypertension? That's never been studied, but that's the kind of thinking outside the box that probably a lot of you end up facing on a daily basis. So in summary, all severe traumatic brain injury patient will benefit from aggressive medical management. Good people, don't need toys, need good people. Patients with suspected intracranial hypertension should undergo ICP treatment with or without a monitor. All severe traumatic brain injury should be done according to treatment protocols. That I can't stress enough. Get your center together and come up with a protocol. And finally, approaches to pre and in-hospital management must be adapted to local realities. Because we don't need fancy toys, but we do need good people. And in this audience, I certainly see good people. Thank you.